So, uh, good morning, everybody. I invite you to this to be a part of this instruction course. I know it's a first day, first show kind of thing, and we have less audience, but I think we need to stick to the time schedule. So we go accordingly. So we begin our instruction course, and I would invite first Dr.Ritika Sachdev to come up on the stage and show us her presentations. And she's an eminent surgeon, and she will be talking to us about the femtocataract, the rupture, and the management.
Thank you, Dr. Priya. It's always a great privilege to be part of your course. I'll be starting with, can you just connect? It's a video, so I'll just be taking you through a video which basically is about managing the vitreous when it surfaces in femtocataract. Now, femtocataract has some unique points. You know that the laser does the capsulotomy. So when the capsulotomy is fashioned by the So when the capsulotomy is fashioned by the laser, you often have areas of microadhesions. It is very important to recognize these areas, though with the newer platforms like the Catalyst and the SoftFit PI, these adhesions are now less commonly seen. So I'll just be starting with a docking procedure. This is with a liquid optic interface of the Catalyst system. You see the overlay of the treatment pattern is seen. The capsulotomy is completed within a few seconds. Then the nucleotomy begins. This is a white cataract, and the reason I'm demonstrating a white cataract is basically because when the fluid comes out from the nucleus, it's moving back. Sorry. ये loop में play कर रहा है वहाँ पे. It's getting stuck. So you see here that the fluid has leaked out, and therefore there is an area which is a skip area. This means that though the capsulotomy has been cut, there is an area which is uncut. At this point, it is important to note you must stain with trypan blue, and when you're pulling the rexus, don't pull it centrifugally. You must make sure that your pull is centripetal so that the rexus is complete, and then you go on with the nucleotomy. This step is important because it is the capsular tag which most commonly lends itself to extension and causes the PCR in femtocataract. The rest of the procedure goes on like a normal cataract. Now I'll be showing you a case of posterior polar cataract which has been taken up on the Femto platform. What is beautiful about the platform is that you're able to image the defect. So you see here, when you zoom in into the OCT, you can see there is an underlying defect. There is a discontinuity in the posterior capsule, and this really is a pre-operative indicator that you will most likely face an intraoperative PCR. At this point, you must increase the posterior offset, which basically means that you have to have a larger epinuclear and an uncut portion to prevent the nucleotomy going too close to the, I don't know why it's just moving back on its own. ये वीडियो वापस जा रहा है. So this is how the case looks after the femto treatment has been done. You see here the sextants are there. What you see on the other side is the intraoperative OCT. The intraoperative OCT actually shows you a little bit of a epinuclear dropping because there is a discontinuity in the posterior capsule. This is the intraoperative OCT. Because the vitreous is formed, if you remove the nucleus without much manipulation, you're able to manage without a PCR. But note here that at the last point, the PCR now is evident. What was most important was that, I'll just go back into this point, that as we are doing the irrigation aspiration, we reach the area of the PCR in the end. We do not withdraw the instrumentation without putting in viscoelastic to tamponade. You see here on the OCT that there is a formed vitreous, though there is a mild herniation from the area of the PCR. What has been done here is a single piece IOL has been placed inside the bag. With such a large slit like PCR, that may not be a great idea. What happens here is, you can see when we hydrate, there is still some vitreous that has surfaced. And you see that the lens is not stable, it is tilting. So what do we do now? We are going to try and position this lens back into the anterior chamber over the iris and then remove this lens. Why it is important to remove this lens is, as you can see, this is a single piece IOL. It is not mandated to put in a single piece IOL in the sulcus, and that is where the lens may need to be positioned in the event of a PCR. A single piece IOL has thick, bulky, square-edged haptics which will rub across the posterior surface of the iris and cause pigment dispersion and lend itself to an inflamed eye. So what you see here, I'm extending the incision slightly, giving a cut halfway through the IOL, engaging the IOL into the incision through this area of cut. This allows you to maneuver the IOL out through a smaller incision by simply cartwheeling it out. At this point, you have to place now an IOL in the sulcus. A vitrectomy is done. You have to make sure that the capsulorhexis is intact. The pupil has come down on us. Do not hesitate to put in iris retractors for better visualization. So once we've put in the iris retractors, we see that the Femto has fashioned a beautiful CCC, and over which a 3-piece IOL is now implanted. A 3-piece IOL is the ideal IOL for implantation in the sulcus. Once a 3-piece IOL is implanted, we're just making sure that we've cleared the vitreous earlier, just making sure that the area is clear of vitreous, and removing the iris retractors. The pupil being regular is an indicator that the vitreous is absent from the anterior chamber. A small suture is placed, and this is how the patient looks like on day 1. I'll now be just showing another case of posterior polar cataract. This is on the LensX platform, which is by Alcon. The treatment of the Femtocataract is similar. You have the capsulotomy being fashioned. On the other side, you see the OCT, wherein you see the nucleus. This is the nucleotomy coming in. You can choose various patterns. The earlier pattern was that of a division into sextants. This pattern is more into smaller cubes, the matrix pattern. The incision and the arcuate to correct astigmatism are then fashioned. Now this is a posterior polar cataract. There is some amount of pneumodissection that has already been done due to the femto firing, but once we remove 2 pieces of the emulsify the nucleus, you see here the red reflex has become very visible and the nucleus is pointing posteriorly. What do we do at this point? We have a posterior capsular rent that has surfaced, and we have non-emulsified nucleus, nearly half of it still in the bag. So this is a technique that we will be following here. You see that we are going to try and pull this nucleus piece into the anterior chamber. You can use posterior levitation, or you can use a blunt instrument which has been put in through a side port to then guide this half of the heminucleus into the anterior chamber. This is sometimes tricky when you have a large rent, but you have to make sure. And what makes it actually trickier in a femtocataract, this has been pre-treated. So it cheese wires. If you're doing it in a normal phaco case, then it actually comes out as a single piece. Now once you have this heminucleus over the iris, we will now go in with the technique that Dr. Amar Agarwal has popularized, which is the IOL scaffold. A 3-piece IOL has to be implanted in the sulcus anyway. So this is a premature implantation of the 3-piece IOL. The IOL is implanted in a way that that one haptic is over the iris, and ideally one haptic should be outside from the wound, so that you're able to retrieve the IOL if required. Now this IOL gives you an artificial separation wherein the nucleus will not fall back into the vitreous. So with this IOL behind the nucleus, the phaco is now used to emulsify the heminucleus. Please note this is a technique which is very safe for soft nuclei. In harder nuclei, you must make sure that the endothelium is protected very well with viscodispersive viscoelastics. So once this 3-piece IOL is safely now guided into the sulcus, because you do the clearance of the cortex, and now the same IOL that has served as your scaffold is implanted into the sulcus. The AC is clear of vitreous, and this is how the patient looks like at the end of the surgery.
23 gauge micro
I'll just
incision
stop here.
trocar
Thank you
cannula
for your
system
attention.
forms the backbone of this instruction course.